Hey class, welcome to another series of our hemodynamic monitoring. This week, we're in our arterial line setup portion. So there's a couple things I want you guys to know because it's very important when you get to your different clinical sites that not all arterial lines look the same. So with that being said, we're going to get into the one that we are going to be using for our assessment. So this one right here is actually going to be a two-set setup. The first one is going to be the actual transducer piece. So this is the transducer. And this right here is going to be the bifurcated spike tubing. And I'm going to take it out of the packaging just so that way you guys can see. This right here is going to be your extension that's going to be added to the end of the arterial line. This is going to be your 500 mil pressure bag. And this is going to be your normal saline fluid. So we're gonna connect everything, but the first thing I wanna get into is making sure that our bag is labeled. So with any fluid, especially with your arterial lines, you wanna make sure that it's signed. So your initials, time, and date. So the first thing we're gonna do is we're gonna put our initials, the time, which is 2006 or 2026 in military time. And then it's going to be the date, which is 4/3/26. So I have my initials, my date, and then my time. It's kind of faint, but you guys get the idea. Next thing we're going to do is going to take it off, put it on side of the label side of the actual fluid. Next thing we're gonna do is we're gonna take our normal saline bag or our pressurized bag, take it out, set it aside. Now, what I'm going to do is I'm going to connect everything in this proper order. So the first thing you're always going to take out is your transducer. So we take our transducer out, looks like this. Comes with our 2 ABG ports. Now, when you take this out, the first thing I want you to do is make sure the cable side is on the bottom. So we're gonna stick this in, set it and forget it. Next thing I want you guys to do is take the bifurcated tubing, toss that, and what you're going to do immediately is clamp one side. It comes with these 2 clamps. You're gonna clamp one of them. Now, with the open side, you're going to take it, go to the bottom of the transducer, twist, and connect. So we're good to go there. And the reason why we're going to leave this one open is because this is the side that the pressure bag is going to go, the normal saline is gonna go through. This side we want clamped, because if you don't clamp it, the fluid's gonna flow out. So we wanna make sure that this one's unclamped and this one's clamped. So we can set it and forget it. Next thing I need you guys to do is going to be connect the extension piece. So you're gonna take it like so, out of the packaging. And then what we're going to do is we're gonna go to the patient side, which is the top, and we're gonna go ahead and connect it to the 3-way stopcock. And then you wanna open it, make sure this stopcock is open as well. And that way it just ensures that we're gonna get that nice even flow when we actually start flushing the pressure bag. So we wanna keep everything aseptic, so we're gonna put this cap back on there, wanna make sure it's sterile, and we can set it to go. Now, it's important to note that not all institutions are going to have the drip chamber full. Some of them want it halfway, but at certain hospitals, they don't want any air in the chamber, and I'm going to be displaying how we get the air out of the chamber. So like I said, it depends. Some will want air in the chamber, or some will leave it halfway filled, and some will want all the air out of the chamber. This one, we're gonna take the air out of the chamber. How we're going to facilitate that is we're gonna take our normal saline, we're gonna put it in the bag with the label facing outward. Put it in. And right here, you'll see a little hook you want to take that hook, put it through the bag like so, and pull it up like that, and then you're good to go. So now at this point, what we can do is we can take our bag, put it on our IV pull our tab off like so, take our spike piece, which is coming from the bottom of the transducer, grab the stem, doing this aseptically, making sure it doesn't touch anything, and put it right into our bag. What we want to do is you're going to press once, fill up the chamber about so-so, and then what we're going to do is we're going to pressurize the bag. So now how we do that is you want to take your stopcock, put it in the neutral position, and we're going to continue to pump. And this might take a while, depend. Sometimes we have little competitions here to see who can do it the fastest. I always win. And you're gonna pump it up until it gets to the green, which is 300 mils of pressure. Now, what you wanna do to make sure the air doesn't come out is you're gonna turn this up. This way is gonna ensure that none of the actual air seeps out of the bag. So like I said before, if we were in an institution where this is perfectly fine and the drip chamber doesn't need any of the air taken out, all we would do at this point is we would have to zero it and we'd be good to go. But some hospitals want the air out of it. So what we're going to do is take out the air. How you're gonna do it is you can invert it, which means turn it upside down like so. We're going to take our patient end, and all you're going to do is flush on this tab here. As I'm flushing, you can see all the air escaping out of the chamber. So now that the air's out of the chamber, we can hold this back up here, but we still need to get the air out of the actual tubing. But it makes it easier when the bag's up there. So now we're just gonna flush. So now we have the air out of the chamber, we have the air out of the tubing. Last thing we need to do is we need to go ahead and flush these ports just to make sure if we were to pull any arterial blood gases or there's no contaminants in that area. So the first thing we're going to do is we're going to pull up on the stopcock, turn it off to the patient, take off the lid, give it a little flush. It's good. Put the cap back on. Go to the second one, which is going to be down here. Open the cap. Flush, and you're good to go. Put the cap back on. And then we're gonna flush it through one last time. We're good to go. Last thing you need to do is flush this side. Now, this side would actually be used if you needed to hook up another hemodynamic monitor, whether it be a central line, whether it be a pulmonary artery catheter, or whatever the case may be. So that's why we wanna flush it. So that way, if we do put another transducer in there, all the air is already out. So what you're gonna do is just take it, get the air out, boom, it's good to go. Now we have completed the setup of our arterial line. Last thing we need to do, guys, is zero it. So it's gonna come with the monitoring cable like so. And what you wanna do is you wanna connect the transducer to the pressure monitoring cable. Now, it's important also to note that every institution is gonna have a different monitor, so it's not gonna look the same. However, the process of zeroing is always going to remain the same. So with that being said, you would move your pull. And I'm gonna come around here to my actual anesthesia monitor. And what you're going to see is this wave right here. You're gonna see arterial line pop up. It says not zero. And how do we zero it? Well, I'm gonna show you right now. So the first thing we're going to do is we're going to make sure that this plate is at the phlebostatic axis of the patient. And what that just means is it's mid-level at the patient's chest. So you wanna make sure that's right midline with that patient's chest, which should be around right here. And like I say, it's important to zero at the phlebostatic axis, because if you zero it too high, your baseline is going to be wrong. And if you do it too low, the same thing. It's not going to be calibrated at the right height. So you have to do it exactly at that patient's mid-level. So what you're going to do is you're going to turn this up off to the patient, take off the cap so it's exposed to atmospheric air. You would come around to your monitor. And like I said before, this may be different from the facility that you're in, but the process is the same. You would go to zero all pressures, says zeroing, it's zeroed. Now I have to go back over to my transducer, turn this back on to the patient. So I would flip the toggle switch of the stopcock, put the cap back on, and if you look, you'll see a waveform up there. And how we verify, we're just gonna move this up and down, and you'll see the waveform. And that's how you would set up an arterial line. Like I said, the only difference would be the monitoring, but the whole process of zeroing is exactly the same. Other than that, good luck on your assessment, and see you guys soon.